Cervical insemination in the bitch, utilising a rigid endoscope, was developed at Glenbred Artificial Breeding Services in New Zealand in 1988 and is now being used in clinics throughout the world. The technique was developed to meet specific objectives. Intrauterine semen deposition would be guaranteed. The technique would not involve surgery or general anesthesia. Repeat inseminations would be possible. It should provide results as good as any other insemination technique. The technique would only require simple restraint without sedation. It could be applied to all bitches. And it could be performed without additional staff. The end result is a technique which allows the intrauterine deposition of fresh, chilled and frozen semen, as well as the performance of other procedures for diagnostic purposes, as a research tool, and possibly for therapy. The cost of the equipment means that it is a major decision to take on board endoscopic transcervical insemination in a practice. You need to know what you can expect from the technology. How easy is it to learn? What are the problems? What are the solutions? And what results can you expect? Let's start with the learning process and what is involved. The attachment of a video camera to the endoscope allows direct training by an experienced operator and is extremely helpful in talking the trainee through the procedure, but many people have taught themselves. A thorough knowledge of the anatomy of the reproductive tract is essential. You must know where things are and what they look like. It is important to develop good technique, learning to manipulate the scope and catheter in a complementary way. This ensures minimal stress to the bitch and good results. Practice is what it's all about. You can only become proficient by practicing the technique on as many bitches as possible. It is important to start with the best possible subjects. More on that later. The aim of this video is to provide anyone wishing to learn the technique with all the information they need to become proficient. It covers the necessary equipment, a refresher course on the anatomy of the bitch reproductive tract, step by step through the basic technique, and a major section covering problems and problem solving. The equipment described here for endoscopic transcervical insemination is manufactured by Karl Storz, but endoscopes made by other companies can be used, provided they meet the critical dimensions required for this procedure. These relate to particular anatomical features found in the bitch reproductive tract. The scope must be long and narrow. The equipment is described as an extended-length cystourethroScope and consists of a rigid telescope which has a 30-degree viewing angle. This field of view is forward oblique, which means when used in this technique, there is only a limited view of tissues below the horizontal plane. The telescope is used in conjunction with a sheath, which has two ports which can be used for air insufflation or irrigation if required. The working length from blue collar to tip is 29 centimeters and the sheath diameter 22 French. These are critical dimensions for an endoscope for this technique. A bridge attaches to the sheath. It has a single instrument channel which takes an 8 French catheter. Assembling the equipment is simply achieved by lining up the symbols and turning the locking rings. Once assembled, note how the telescope tip sits within the sheath, slightly back, which provides protection, but does mean that vaginal discharges can collect there. A cold light source and cable completes the essential equipment. The endoscope can be used with or without a camera and monitor. Having used the scope without the advantage of a camera for 10 years, I can assure you it is quite an acceptable procedure. This camera is small, easy to attach, and there is no doubt that adding the camera to the system makes the whole technique more user and client friendly. They can see what is happening, and it is easier to manipulate the scope. It does, however, add significantly to the cost. A small TV monitor like this is adequate for transcervical insemination, but if endoscopes are used widely in your practice, then it is worth investing in a high-quality medical monitor which provides better resolution. Effective restraint of bitches is essential, but can be simply achieved on this stand I designed. It protects both bitch and equipment and dispenses with the need for an assistant. Bitches are secured by their collars, and a rubber mat provides a non-slip surface to stand on. The abdominal band limits sideways movement and any attempt to sit. Most bitches and estrus are happy to stand and show no objection to this method of restraint. Obviously, fidgety or difficult bitches require the help of an owner or an assistant. The stand is placed on a hydraulic table to ensure bitches can be examined at the optimum height. After all, there is a wide variation in size of bitches. Without the camera, the need to always be at eye level and take account of the angle of the vagina and position of the cervix is impossible to achieve in one position. A hydraulic chair is also helpful, as it is very tiring to work in a less than ideal position. With the camera attached, it is easier to have the bitch in the optimum position relative to the operator. One piece of equipment which should not be forgotten is the obturator. You will see later that this is not just a piece of packing that arrives with the endoscope, but is in fact a useful piece of equipment. The last piece of equipment is the insemination catheter. I use a modified 8 French urinary catheter, which differs from a standard urinary catheter in having one terminal hole in place of 2 side holes. These are no longer available, so in the meantime standard urinary catheters are the only option, and they work perfectly well in most situations. The side holes should be as near the end as possible. Occasionally, for small, difficult or maiden bitches, smaller 6 French urinary catheters are preferable. Moving on to our anatomy refresher course. In order to catheterize the cervix, it is essential to be familiar with the anatomy of the bitch reproductive tract. There are features which you must be able to identify in order to know where you are. You must know what your destination looks like and what to avoid on the way. Some of the features determine the dimensions of the equipment suitable for transcervical insemination. We are concentrating on this caudal part of the reproductive tract, from vulva to cervix. Starting at the lips of the vulva, the first significant feature is the clitoris within the clitoral fossa. It is located within the ventral commissure of the lips and is a sensitive area to be avoided when introducing instruments. Moving through the vestibule, the next feature is the urethral tubercle, which is located ventrally, just caudal to the vestibulo-vaginal junction. It contains the urethral orifice, and care has to be taken to ensure the endoscope is not introduced into the urethra instead of the vagina. Remember the marked change of direction from vestibule to vagina at this point, so that following up over the pelvic brim means that it is a relatively easy mistake to make. The cingulum is to be found at this point, just in front of the urethral tubercle. It is an annular, narrow band-like constriction which acts as a functional sphincter at the vestibulo-vaginal junction. This is the position where annular strictures are found which prevent natural matings. There are rarely any problems passing an endoscope in these situations, provided care is taken to identify the restricted lumen. Such bitches usually welt without any problems. This main part of the vagina is made up of longitudinal folds, which vary significantly in size depending on the stage of the reproductive cycle. In proestrus, the folds fill the lumen, but as estrus progresses, they shrink back. It is this cranial portion of the vagina, which I will refer to as the paracervix, that presents the most significant features relative to transcervical insemination. You must have a clear picture in your mind of the main structures and how they relate to each other. Starting with the dorsal median fold. This is a well-developed fold which dominates the paracervix, and as the name indicates, it is suspended from the dorsal wall of the vagina. In this specimen, we are looking at its ventral surface. The dorsal median fold is important because it significantly reduces the vaginal lumen in the approach to the cervix. This limits the diameter of any equipment which can be passed through this area. The move to the paracervical area is obvious, as the dorsal median fold reduces the vaginal lumen to a crescentic shape at this point. The next important landmark is the cervical tubercle, which is the vaginal portion of the cervix. The dorsal median fold extends cranially to the cervical tubercle. The cervical tubercle is quite tubular in shape in most bitches. Looking at this lateral view, note also the distinct transverse fold which separates the dorsal median fold and cervical tubercle. The cervical tubercle is seen as a distinct entity in front of and below the dorsal median fold, with the obvious transverse fold separating them. The cervical canal and external os are the next features to consider. The cervix lies diagonally across the uterovaginal junction as seen in this lateral view of the tubercle. The cervical canal is therefore directed craniodorsally from the vagina to uterus. This means that the external orifice is seen to be directed to the vaginal floor. This almost ventral location means the os is frequently not immediately visible. The fornix is the final landmark in this area. The vagina is limited cranially by the fornix, which is a slit-like space cranioventral to the cervical tubercle. It is an area you must be able to recognize when using the scope. The cervical canal is patent throughout the reproductive cycle of the bitch, but catheterization can be performed more readily at some stages of the cycle than others. The cervical canal is approximately 1 centimetre long in this anestrus bitch, but is probably considerably longer during estrus. A muscular membranous projection extends into the body of the uterus and should be remembered when passing a catheter into the uterus. The vagina of the bitch is particularly long. The length from vulva to cervix can be up to 29 centimetres in large breeds such as the St. Bernard and Newfoundland. This has a significant bearing on the choice of suitable endoscopic equipment for transcervical insemination. In summary, the length of the vagina, narrow paracervical area due to the dorsal median fold, position of the cervical os, angle and diameter of the cervical canal are all relevant to the execution of transcervical insemination. We can now move on to the actual transcervical insemination technique. With the bitch restrained on the table and the endoscope assembled with the catheter in place, we are ready to start. The vagina is not a sterile environment, but it is important not to introduce any unnecessary contamination from the environment, so the vulva is cleaned. Make sure the catheter is positioned so that the tip is withdrawn well into the sheath to avoid any possible contamination of it during introduction. Some lubrication of the endoscope sheath is required to ensure easy passage of the scope through the vaginal folds, but I like to keep this to a minimal amount. Avoid getting it on the telescope tip and of course the catheter. The endoscope is introduced through the dorsal commissure of the lips of the vulva. Remember, the clitoral fossa and clitoris are just inside the ventral commissure, and introducing the scope there causes significant discomfort and resentment by the bitch, so make sure you don't go there. The angle of introduction is important to take account of the slope of the vestibule and ensure smooth passage up and over the pelvic brim. Remembering, of course, the position of the urethral orifice and how easy it is to pass the tip of the scope into the urethra, which bitches generally resent. It is important to concentrate on introducing the scope correctly, watching where you are placing the scope, the angle of introduction, and moving to the horizontal position without causing discomfort to the bitch. I find it helpful to lift the scope slightly using my left index finger from behind to ensure the tip clears the urethral area as you move to the horizontal plane. At the same time, transfer your attention to the monitor to confirm the scope is in the vagina as here. This is the urethra where you shouldn't be. Remember what it looks like and don't go there again. Back to the vagina. Progress is observed via the monitor. Once into the folds of the vagina, the scope is advanced under gentle pressure, observing and following the direction of the vaginal lumen. In proestrus and early estrus, as in this case, the rounded vaginal folds and excess fluid can make advancing the scope more difficult, as they tend to fill the lumen. The catheter can be used to keep the folds off the tip of the scope if they block your view. In bitches like this in later estrus, the dehydration and shrinkage of the folds results in a more spacious route. It is important to keep the tip of the scope in the lumen as much as possible, as it makes it so much easier to advance the scope. Many bitches resent the tip of the scope being pushed along the dorsal wall. The direction of the vaginal lumen can vary enormously between bitches, from horizontal to sharply angled up or down. You must identify where you are as you go through the body of the vagina and be able to locate the way into the paracervical region. Here we are at the beginning of the paracervix. The dorsal median fold and narrow crescentic lumen are quite distinct. As we progress into the paracervix, the dorsal median fold initially sits on the scope. This tends to obscure vision, so it is preferable to pull back and using the tip of the catheter push the dorsal median fold out of the way and go down the side of the dorsal median fold. The lateral and ventral walls of the vagina in the paracervical area are smoother than the dorsal median fold, so allow you to identify which side of the dorsal median fold you are on. You will usually encounter 2 or 3 distinct folds across the dorsal median fold as you progress through the paracervix. You may initially mistake these for the cervix until you become familiar with the appearance of the os. The vaginal portion of the cervix appears as a distinct tubercle below the dorsal median fold, though the cervical os is not immediately obvious because of its ventral location. The scope is manipulated under the tubercle until the cervix can be visualized. The os is located in the center of a rosette of furrows. The position of the os can also be identified by the presence of discharge issuing from it. The catheter is advanced into the cervical os by manipulation of the endoscope and catheter together. Once the tip of the catheter is introduced into the os, it is steadily advanced using a twisting movement to aid its passage through the cervical canal. For semen deposition, it is passed in as far as it will go without force. The semen is inseminated slowly, and the insemination is visualized all the time to ensure there is no excessive backflow. If this happens, then the catheter should be repositioned slightly within the uterus, either further in or withdrawing slightly, and insemination recommenced. A small amount of air is introduced into the catheter to ensure all the semen is inseminated. It is important to develop good scope handling technique to minimize discomfort for the bitch and to achieve cervical catheterization. I am right-handed, and during scope introduction I hold the scope in my right hand for maximum control. But once the scope is into the vagina, I transfer the scope to a firm hold in my left hand and use my right hand to manipulate the catheter. Let's see that again. By avoiding the clitoris and urethra and keeping the tip of the scope in the vaginal lumen, you will avoid upsetting the bitch. For optimum technique, you must have both hands on the equipment at all times, because you must learn to manipulate the scope and catheter together. A happy bitch is easier to work with, and good technique means you can do the procedure quickly. Bitches in estrus exhibiting standing behavior show excellent tolerance to the technique. I have never found sedation necessary. Initially, practice on medium-sized bitches, as they are easy to handle. Preferably, they should have had a litter, as there is usually more room through the paracervix. Smaller bitches can be more difficult to restrain, and there is less space in the vagina, so don't make ideal practice subjects. Similarly, bitches in proestrus are not ideal, as they are not standing so well, The folds fill the lumen and there will be more fluid present. You should examine these bitches, but don't dwell on them until you're more confident. Bitches well in estrus like this are the easiest subjects. The folds have shrunken back and the bitches stand well. Once you know what you're doing, use the scope on every possible estrus bitch, even if you are not doing an AI, because you can only learn all the variations by experiencing them. Use the scope to practice vaginoscopy, then go looking for the os. Whatever you do, don't keep the scope for special occasions. For the technique to be widely adopted, it is essential that it can be successfully applied to all, or at least most bitches, and it is important that the majority of bitches can be inseminated using the same endoscope. Looking at the vast array of breeds presented with regard to size and shape, this would appear unlikely, but is in fact for the most part possible. The maximum length of the vagina is a critical dimension. However, no bitch has so far been examined where the cervix is beyond the reach of the equipment described. So although a critical dimension, the length of the vagina is not a problem if you purchase the correct equipment. It needs to have a working length of 29 centimeters. The external size and shape of a bitch does not accurately predict the internal situation. Some medium-sized bitches, such as Huntaways and German Shepherds, have vaginas as long as much larger bitches. And some bitches, such as Wolfhounds, Borzois and Afghans, have surprisingly short vaginas. The one limiting factor identified is the amount of space in the paracervix. In some bitches the scope goes easily under the dorsal median fold, as in this case. In many, the optimum route is up the side of the dorsal median fold, making use of the catheter to keep the fold off the scope. In some, however, there is very little space. It is hard to maintain visibility in these cases. By applying steady pressure and changing the angle of the sheath to make the most of the available space and withdrawing the catheter, it is possible to get through this area in most bitches. But in a small percentage of bitches, it is impossible to advance the endoscope through the paracervix. This occurs in some maiden bitches of small or medium-sized breeds and in some toy breeds such as Chihuahua. If this occurs, it is worth trying taking the bridge off and using the telescope without it. You will reach the cervix okay with the telescope, but you are left with limited manipulation of the catheter, but sometimes it works. In some bitches, access to the cervix is impossible. The standard endoscope described here has been used successfully on many small and toy breeds, so is suitable for the majority of bitches, but if toy breeds are a significant part of your workload, investment in a smaller scope may be necessary. With very small breeds, restraint of the bitch is a large part of the problem, and sedation may be the answer. The ability to identify the os comes down to experience of what it looks like, where it's usually located, and how to search for it. The cervical tubercle varies significantly in size and shape and appearance in different bitches and at different stages of the estrus cycle. Compare this with this next specimen. The variation in shape of the tubercle is obvious, as well as the appearance of the os. The os is usually found in a rosette of folds. You must be able to distinguish these folds from those on the dorsal median fold and cervical tubercle. The folds surrounding the os can vary significantly in different bitches, as seen in these next examples. We expect to find the os in this ventral position in the center of the tubercle. But at times it is not found in this expected position. It can appear to be on one side, or in this case towards the back of the tubercle, or on the other side. In a mobile tubercle like this, it can even appear to change position. Here it appears on the right side of the tubercle. You must have a planned approach to find the cervix, not just hope you will stumble across it. As you move through the paracervical area, it is important to recognize where you are in relation to the dorsal median fold, either to the right or left, so you know where to expect to find the os. This approach is down the left-hand side of the dorsal median fold, with the relatively smooth lateral wall on the left, and folds on the dorsal median fold and tubercle on the right. Note these two well-developed folds, as well as the surface folds on the tubercle. Before finally identifying the furrows around the os. In order to find the cervix, advance the scope well into the fornix, then move it under the ventral surface, and the cervix comes into view. The approach is the same from the other side. Go well into the fornix and move the scope under the tubercle. On this specimen you can see what we're trying to do. The most difficult os to find will be located cranially on the tubercle. It is not found because the scope is not passed or cannot be passed far enough into the fornix. All that can be identified are folds on the tubercle. A few more folds and some fluid indicate the position of the os. Having located the os, the ability to catheterize the cervix depends on three factors. Firstly, positioning the os directly in front of the scope, which means lining up the whole tubercle in front of the scope. Secondly, getting the angle of the scope, and therefore the catheter, correct relative to the angle of the cervical canal. And thirdly, using a catheter that will go through the canal. The os has to be positioned so that it faces the scope, and therefore catheter, in order to place the tip of the catheter into the os. In this case, with the os positioned as it is impossible to get the tip of the catheter into the os. The os has to be manipulated from this position to fully in front of the scope. So how do we accomplish this? The aim is to move the scope across the ventral surface of the tubercle and advance the catheter into the os as it comes into view. Go well into the fornix and roll down and under the cervical tubercle. Be ready to advance the catheter as you move under the tubercle. It is important to allow the tubercle to roll slowly over the scope and catheter, and always be ready to push the catheter forward as the os comes past. Once the tip is in the os, apply steady pressure, twirling the catheter, and advance the scope. The straight-on approach can be successful. However, there is a tendency to push the tubercle away. In order to bring the os towards you, you have to go past it into the fornix and apply pressure as you come back. A tubercle like this will move more readily. When the os is to one side, it is impossible to get the tip of the catheter into the os because the catheter is pushing past all the time. The approach is from the side, going past, and attempting to pull the tubercle back and under by gentle pressure on the scope, rolling under at the same time. The os has been moved from the right but cannot be caught by the catheter. This is a very mobile tubercle, and the os is now on the left-hand side. We now have to apply pressure with the scope and catheter from the left in an attempt to bring it back round. As soon as you can apply some pressure via the tip to the os, you are winning, as this stabilizes the os. Maintain pressure to bring the os in line with the scope. Then relax the pressure a little, but don't let it get away. This allows the tubercle to lift as you move the scope forward. Keep varying the pressure on the catheter and moving the scope forward to bring the os into full front position. At the same time, twirl the catheter to assist passage through the cervical canal. The second factor in catheterization is getting the angle of the catheter right. In this example, the catheter appears to be in the cervix okay, but as pressure is applied, the cervical tubercle is pushed backwards, and it can be seen that the catheter has not gone through the canal. The reason for the problem relates to the conflicting angles of the cervical canal versus the scope and catheter. Ensuring the catheter advances once the tip is in the os depends on applying pressure at the correct angle. Remember, the canal is directed craniodorsally from the os, and the aim is to get the scope and catheter at a complementary angle. In this case, the angle of approach and the canal are virtually at right angles, which will cause problems. The angle of the vaginal lumen, and therefore scope, varies between bitches. This angle of approach is obviously better. and this is better still. Here it is obvious that the tip of the catheter is pushing against the back of the canal. Eventually, by applying steady pressure, it finds the right angle, and the tubercle envelops the catheter, showing it is well in. Whilst applying pressure can work in some cases where there is not a major conflict of angle, there are better ways to solve the problem. This bitch has a steeply angled vagina. Obviously the angle of presentation has to be changed. The angle is changed by lowering the camera end of the scope to a more horizontal position or lower. The sequence of events for catheterization is to first locate the os and put the tip of the catheter into it, bring the os in line, and then bring the os up in front of the scope and change the angle. Always twirl the catheter to aid catheterization. Sometimes it is impossible to get the optimum angle of approach, then a smaller gauge, more flexible catheter can help, because it bends under pressure and finds its own way in as you twirl. Try twisting the catheter both ways to find which way turns the os to best advantage. I have never had one break. Equally useful is a catheter that has been moulded from the straight form by heat. Sometimes progress is limited by the diameter of the canal, and a 6 French gauge catheter is necessary. If we are using an endoscope, then obviously we need to be able to see where we are going. Loss of vision like this has 3 main causes: fogging, excess fluid, and thick vaginal discharges. This is the ideal situation, but unfortunately it is not always this clear. Frequently, this is the kind of view you can expect, and when you know where you are going, you tend to put up with this degree of loss of vision. Fogging as you introduce the scope occurs regularly. It may go away if you just keep going, or it can sometimes be cleared by deliberately touching the lens onto a vaginal fold. If neither of these options work, it may be necessary to remove the telescope. Rinse it and replace it. Vaginal discharges resulting in poor visibility can be a major problem, particularly in the learning phase. As estrus progresses, the amount of discharge usually diminishes, which is the time when you'd be doing inseminations. However, in some bitches, significant volumes of fluid are present throughout estrus. In many cases, just continuing through the fluid works, as it tends to be in pockets, and it is still possible to locate the cervix for insemination. Very occasionally, and I have only done this twice in 14 years, it may be necessary to remove the fluid through the catheter. Discharges vary in type, and thick discharges can also cause problems by collecting in the end of the sheath and covering the lens. Sometimes you can keep going in these situations. In this bitch, 5 minutes later after collecting the semen, the situation has changed significantly and visibility is much improved. Despite the abnormal nature of the discharge in this bitch, she whelped a litter of 8. If it is impossible to work through the discharge, then washing the telescope as before can work, but as soon as you start again, the problem is likely to recur as you pick up further discharge in the end of the sheath. Another way of dealing with particularly thick discharges is to use the sheath with obturator in place and introduce this into the vagina as far as it will go. You are aiming for the cervical tubercle. The endoscope is then reassembled. The objective is to deliver the tip of the telescope to the os without collecting a lot of discharge en route. This way you should have a clear view of the os for insemination. Some discharges respond to antibiotics, with the vision improving significantly post-treatment, though in my experience these discharges do not generally indicate an infection which has any effect on fertility. I always examine the bitch prior to collecting or thawing semen to confirm catheterization is possible, identify any problems, and confirm the stage of the cycle vaginoscopically. With visualization of the cervix, there can be no doubt that the catheter is intrauterine. Continued viewing of the insemination process ensures that the semen is deposited in the uterus without backflow occurring. A radiograph shows that radio-opaque material is present throughout the horns of the uterus immediately following insemination. However, not all inseminations go according to plan. Backflow can be a problem. There are 3 reasons why this happens. Firstly, poor positioning of the catheter, not far enough into the uterine body. Secondly, the catheter type can make it more likely. And thirdly, the insemination volume is important. If we look at catheter position and type first, it is essential that the tip of the catheter passes through the cervical canal and well into the body of the uterus to ensure semen is deposited in the cranial part of the uterine body or even in one horn. This is using the catheter with the terminal hole. With a standard urinary catheter with 2 side holes, the catheter has to be advanced further into the uterus to ensure the second hole on the catheter is well within the uterine body. With the walls of the uterus in close contact with the catheter, semen from the terminal hole will naturally go forward, but from the side holes there will be more of a tendency for it to come back along the catheter, so it is essential it is well into the uterus. The second hole must be well in. In order to make sure this happens, it is important to mark the catheters so you know how far in they are. With the catheter at the end of the scope, make the first mark. Advance it approximately 2 centimeters to represent the distance the tip will be into the uterus and mark again. Advance a further 2 centimeters as the distance in you would like to be and mark again. When you catheterize the cervix, you can then see by the marks showing on the catheter how far in you are. With the standard catheter and side holes, you have to allow for the position of the back hole relative to the uterus, so your marks relate to the back hole, not the tip of the catheter. Given the increased potential for backflow with this type of catheter, your marks should represent the catheter very well into the uterine body or horns. Remember the internal projection in the uterine body. Your catheter may get wedged here and require manipulation in and out to try and get the catheter further in. Other open-ended catheters are available, but their blunt-ended shape means they do not go into the os anything like as easily as the bullet-shaped tip. If large volumes of semen are inseminated, you will get backflow. The maximum I inseminate is 3 ml. If the fresh semen collection exceeds this, I spin the sample to reduce the volume. Use only a small volume of air to clear semen out of the catheter. Inseminate slowly and watch so that the air does not cause backflow as well. Back pressure can be a problem with the terminal hole catheter, usually due to picking up some tissue in the hole, so make sure you have the semen syringe securely attached to the catheter and apply pressure. Back pressure may also be due to uterine pathology. The risk of trauma or infection resulting from the procedure are important considerations. It is difficult to imagine that the plastic urinary catheter could ever perforate the vaginal or uterine wall during oestrus, unless a pathological condition already existed. However, the paracervical area can be traumatized by the endoscope by the use of inappropriate force. If advancing the endoscope causes obvious discomfort to the bitch, then the procedure should be stopped. It has been suggested that transcervical insemination could introduce infection to the uterine environment. During proestrus and estrus, bacteria are routinely isolated from uterus and vagina without apparently causing any problems, perhaps due to a greater resistance to infection at this time. Therefore, it is reasonable to assume that advancing a catheter from vagina to uterus at this time will not cause any problems. However, care must be taken to ensure no new infections are introduced as a result of inadequately cleaned equipment or from the environment through poor technique. During diestrus, the situation changes, and the uterus, under the influence of high progesterone levels, may be particularly susceptible to trauma and infection, requiring special care and aseptic technique at this stage. The presence of a hair within the vaginal lumen reminds us this is not a sterile environment. The most important thing you must remember about transcervical insemination is that it is simply a means of depositing semen in the uterus. With frozen semen, this is a vital part of the technology, but it is only one part of the technology. Equally important to the successful use of frozen semen are the correct timing of insemination, the semen quality and quantity, and the bitch fertility. Endoscopic transcervical insemination, like any other intrauterine insemination method, will only be successful if all these factors are taken into account. It is easy to think only in terms of frozen semen use in conjunction with transcervical insemination, but when used for chilled and fresh semen inseminations, you will achieve much better results than from vaginal insemination. What's more, it is possible to achieve pregnancies with extremely compromised semen with intrauterine deposition. Transcervical catheterization can also be used for uterine microbiology and biopsy, and for hysterography. Dr. John Watts from Australia has already utilised the technique for research purposes, and with the ability to catheterise the cervix comes the possibility of developing new diagnostic procedures and perhaps therapy. In addition to cervical catheterization, the endoscope can also be used for routine vaginoscopy to determine the progression through the reproductive cycle, as well as for diagnostic vaginoscopy and cystoscopy.